I'm honored and very excited to present the session called Obstructive Sleep Apnea in Children, How I Do It. We've got some great talks ahead of us delivered by our 4 expert speakers. First, Dr. Kirkham and Dr. Lamb will share how they use DISE, Drug-Induced Sleep Endoscopy, for upper airway evaluation and how these findings are applied in surgical decision-making. This will be followed by our final 2 speakers, Dr. Benedek and Professor Verholst, who will tell us about surgical and non-surgical treatment options for persistent OSA in children. You will all have the opportunity to write any questions during the sessions in the chat. And at the end of the session, we'll have time for a Q&A. And please address the questions to the particular speaker you want to ask. So yes, please now welcome our first speaker here today, Dr. Aaron Kirkham, who is a pediatric otolaryngologist and an assistant professor at the Department of Otolaryngology, Head and Neck Surgery at the University of Michigan. She will tell us about drug-induced sleep endoscopy as a tool for upper airway evaluation in pediatric OSA. Go ahead.
All right, let me just share my screen. Okay. Tina, are you seeing my slides there?
Yes, you're fine.
Okay, great. So thanks for the introduction. I'm really happy to be here. I'm Aaron Kirkham from University of Michigan, and I'm going to talk today about pediatric drug-induced sleep endoscopy, how I and others do it. So my only disclosure is that I'm a contracted author for UpToDate. The objectives of this talk will be to briefly define the goals of pediatric sleep endoscopy, discuss indications and aesthetic considerations in children, some details of DISE technique, DISE scoring scales, and then highlight some specific DISE findings. Sleep endoscopy, or DISE, is a fiber optic upper airway examination performed under anesthesia that is titrated to put the patient into a sleep-like state in which they're unaware of the scope, but breathing spontaneously. And the goal is to diagnose and quantify the site and degree of upper airway obstruction in order to direct treatment. And here's what it looks like. So the top of the screen in this view is anterior, and you can see there's the nasal septum, the adenoids, the soft palate. Going forward a bit, looking at the lateral pharyngeal walls, very small tonsils in this child. The epiglottis is coming into view, as well as the tongue base, and you can see the uvula flopping down over the tongue base a bit. And that's the impact of jaw thrust. You can see the lingual tonsils there and the supraglottic structures. So while DISE has been used for over 20 years to guide sleep surgery in adults, the indications for pediatric DISE are less clear. Most agree that DISE is indicated for persistent post-adenotonsillectomy, or AT-OSA. Many argue, though, that DISE prior to AT in normal, healthy children without risk factors for persistence is not efficient or cost-effective due to the high frequency in general of adenotonsillar obstruction in this population. The main controversy is the utility of DISE prior to AT for children that have a higher risk of persistence or multi-level of obstruction. Last year, IJPO published a Delphi consensus statement on the management of pediatric OSA, and in fact, several of us on today's panel participated. And one of the questions asked as part of the process was, which of the following conditions are an indication to perform DISE? And the highest agreement was for children with Down syndrome and craniofacial abnormalities, whereas there was less agreement in young children, healthy children with moderate to severe OSA, and in cases of obesity. In my own practice, I reserve DISE primarily for cases of persistent post-AT OSA. And I advocate for AT as a first step, even if a child has a risk factor for post-AT persistence, because in my mind, it's very hard to predict the benefit of TNA in any given child. And I think removing the tonsils and adenoids and then establishing a new baseline just helps simplify the decision-making from there. And even though many series suggest that multi-level obstruction is common, seen in anywhere from 40 to 80% of children, depending on the study, we don't have any studies yet with controls, and thus we don't know how multi-level surgery compares to TNA alone, or whether obstruction at non-AT levels persists after the tonsils and adenoids are removed. So that's not to say that I don't ever perform DISE prior to AT, but I do so when a patient has, in general, 2 or more risk factors for multi-level obstruction. For instance, in a child with Down syndrome who's less than 2 years old with small tonsils and severe OSA, I will perform DISE prior to AT. And primarily in this case, I'm looking for sleep state laryngomalacia, as I may perform a supraglottoplasty. Anesthetic protocols for pediatric DISE have also been a point of controversy. An interesting finding of the IPOG consensus statement was that there is no consensus really on anesthetic choice for pediatric DISE. 58% of respondents use propofol, 50% dexmedetomidine, and 31% an inhaled agent alone. And the overlapping percentages indicate that some surgeons use more than one routinely. As standard of care, most children require mask induction with a volatile agent like sevoflurane to facilitate IV placement. But SIBO is not ideal as a sole agent for DISE because of unpredictable pharmacokinetics, which make it difficult to titrate to that perfect sleep-like state without risking apnea and airway obstruction. And in terms of impact on the upper airway, SIBO decreases upper airway muscle activity and increases upper airway collapse. And so for this reason, I usually ask my anesthesiologist to turn the gas off as quickly as possible after IV placement. And we try to allow as much of it to be breathed off before starting DISE as we can. Propofol is the most common pediatric IV anesthetic used overall. And most anesthesiologists prefer it due to its rapid pharmacokinetics and easy titration to a reliable depth of sedation. A downside is that it does suppress sleep-like EEG activity, so it doesn't put the brain into a sleep-like state per se. And it also has effects on the upper airway with decreased cross-sectional area with increasing dose. So a caution with propofol is that it may exaggerate upper airway obstruction relative to sleep on average, but it's probably giving us a picture of the airway at its worst state of apnea. Dexmedetomidine is also a solid choice of IV agent, often used in conjunction with ketamine. And compared to propofol, Dex has slower pharmacokinetics, and in general, it requires a slow titration due to the risk of bradycardia, and provides an overall less reliable sedation than propofol. But a plus is that it has some EEG features that overlap with natural sleep, particularly stage 2 sleep. It also has less impact on the upper airway. As with Dex sedation, there are preserved upper airway reflexes and preserved respiratory drive. So in theory, it might actually improve upper airway obstruction relative to the worst obstruction seen during sleep, but it may be giving us an overall a better sense of the average obstruction during sleep. Ketamine is given as an IV bolus in conjunction with the other medications sometimes. It has rapid pharmacokinetics and minimal effect on respiratory drive. It increases upper airway dilator activity, so it can deepen the anesthesia plane without precipitating obstruction or apnea. But like Dex, it may actually improve upper airway obstruction somewhat relative to the worst obstruction seen during sleep. Opioids should be avoided because they increase the risk of obstruction and apnea due to their suppression of upper airway reflexes and respiratory drive. So they should be given during the anesthetic after DISE if needed. I also try, if possible, to avoid pre-medication with benzodiazepines because they also increase risk of obstruction. And I never use topical anesthetics prior to the DISE for the same reason, because they increase the risk of obstruction. We performed a retrospective comparison of sleep endoscopy findings in children that were anesthetized with propofol or dexmedetomidine at our center at Michigan. And we didn't actually find a significant difference in the odds of high-grade obstruction at any of 5 levels of the airway between the 2 drugs. So despite apparent subtle differences in upper airway relaxation and reflexes, it may not matter that much when it comes to DISE score and surgical decision-making. However, a well-controlled prospective study is really needed to confirm these findings. So until that happens, I find I default primarily to propofol. In terms of my personal DISE technique, I position the patient supine on the OR table, no headrest in general, so ignore that, and no shoulder roll. And I ask the anesthesiologist to place a nasal cannula on low flow to use judiciously as needed, and always have a flexible suction catheter available. I stand at the head of the bed. I do it upside down, which has the benefit of being able to control the airway and manipulate the patient's head position and mandible with the non-dominant hand. I video record all endoscopies and evaluate the airway from the nose to the vocal cords. I don't usually perform a bronchoscopy unless I'm concerned about a lower airway lesion. This avoids laryngospasm because the airway isn't anesthetized, and bronch is usually not necessary with DISE as the diagnostic yield of tracheal assessment is low at less than 5%. And I use the University of Michigan sedation scale to judge the depth of anesthesia because it's more reliable than BIS in children. And we aim for a sedation depth of 3, which corresponds to deep sleep, arousable only with significant physical stimulation. So there are 6 scoring scales that have been published for use in pediatric DISE, and they differ in terms of the scoring scale, 2-point, 3-point, 4-point, and the level of the airway scored. No scoring system correlates well with OSA severity on PSG, and none has been validated to outcomes. So the predictive value of any one DISE scoring system is at this time unknown. The lack of correlation to PSG, though, doesn't mean that DISE isn't useful. We know, for example, that sleep symptoms and quality of life don't correlate well with OSA severity on PSG, but both are useful measures of disease burden. And DISE has value for identifying site of obstruction and guiding intervention, but it doesn't replace polysomnography for diagnosing OSA or predicting OSA severity. And I think many of us agree that research on pediatric DISE could benefit from consensus on a scoring method. And I think validation against clinical outcome would be the most helpful way to do that. But until we reach some kind of consensus, at Michigan, we use the Chan-Parikh Scale, where obstruction is graded from 0 to 3 visually based on percentage of luminal obstruction at each level, as shown here. My partners and I document DISE using the same OR note template, which is helpful for standardizing findings. And we also document some findings not contained in the score, including nasal obstruction and lingual tonsil hypertrophy. And I use the grading scale published by Norm Friedman in 2016. I also document always whether I see epiglottic prolapse. And as you can see, it's not a large tongue base or big lingual tonsils that are pushing back against the epiglottis in this DISE video, but it's the epiglottis that's acting almost like a suction cup, and that can be corrected with epiglottopexy. It's also important to look when you're evaluating the palate to look at the impact of jaw thrust on palatal collapse, because if it's the tongue pressing back against the soft palate, that might actually predict failure of any palatal surgery. When it comes to scoring scales, really, I recommend picking one, using it consistently, documenting any additional findings that the score doesn't capture, and try to standardize across your group so that you're all speaking the same language. And so in summary, I'll leave you with these key points. DISE is a useful tool to guide OSA surgery in children with persistent post-AT OSA. Its role in surgically naive patients is less clear, but I think Dr. Lamb's going to talk a little bit about that. It's unclear at this point if anesthetic choice really matters in terms of surgical decision-making, but I think more research is needed. And no scoring system is necessarily superior. I think the important point is that from anywhere from your patient positioning to your anesthesia to your scoring protocol, consistency is key so that you can develop your own consistent thresholds for surgical intervention. And that's all I have. I just want to acknowledge that quite a lot of how I do it and why I do it comes from the wealth of experience, tips, and tricks that I've learned from the people who've either trained or mentored me. So I want to thank them. And if anybody has any questions, feel free to email me.
Thank you very much, Dr. Kirkham, for your comprehensive talk. We will now be taken further into the subject of whether DISE can or should change the surgical plan in a child plan for adenotonsillectomy. This will be done by our next speaker, Dr. Derek Lamb from the Department of Otolaryngology, Head and Neck Surgery at Oregon Health and Science University. The word is yours, Dr. Lamb.
Thank you, Tina, for the introduction, and thank you to Dr. Boudwins for putting this panel together. Yes, so this morning I'm going to talk about, should DISE change the plan in a child with planned adenotonsillectomy for sleep apnea? And I have no relevant disclosures. So before we can really ask the question of should DISE change the treatment plan, I think we have to ask, can DISE change the treatment plan? Typically, the primary physical exam finding that we use to determine whether to plan an adenotonsillectomy for a child with sleep apnea is whether their tonsils appear obstructive during an awake clinical exam. So the simplest way to look at whether DISE can change the treatment plan is to compare DISE to the awake clinical exam with respect to tonsillar hypertrophy. So there is a solid body of literature that shows that awake clinical assessments of tonsil size do not correlate well with the baseline sleep apnea severity, and a pretty solid body as well that suggests that awake clinical tonsil assessments do not correlate with response to adenotonsillectomy. But how do tonsil scores compare to DISE ratings of tonsillar obstruction? This is data from a paper that we published showing that children with clinically small tonsils, so 1+ tonsils, and children with kissing 4+ tonsils on the Brodsky scale do not correlate well with DISE ratings, showing no, or they do, correlate well with DISE ratings. So there's no significant obstruction during DISE for the 1+ tonsils, and complete obstruction in general for the children with 4+ kissing tonsils in the clinic exam. But for children with intermediate Brodsky scores, which is most of the children that we see, there was a wide range of tonsillar obstruction during DISE. This suggests that awake upright clinical assessment of tonsil size may not accurately reflect the dynamic obstruction seen during DISE. With the outcomes of adenotonsillectomy, we performed a linear regression analysis looking at several polysomnography parameters. So these beta coefficients represent the strength of association with the change after adenotonsillectomy. So a larger negative number, for example, indicates fewer obstructive events for the obstructive apnea-hypopnea index, the REM-AHI, and the oxygen desaturation index. And a larger positive number indicates a higher oxygenator after adenotonsillectomy. And the bold here indicates that DISE ratings were all statistically significantly associated with improved polysomnography parameters, while the awake Brodsky scores were not associated with any change after adenotonsillectomy. And moreover, these R-squared values shows the proportion of the variance for each of these parameters associated with either the Brodsky score or the DISE ratings. And you can see that the DISE adenotonsillectomy ratings accounted for a far greater proportion of the change after adenotonsillectomy than the awake Brodsky scores. So unlike clinical exam, DISE ratings are associated with the outcomes of adenotonsillectomy. And so I think we can reasonably say that DISE is better than an awake clinical exam for surgical decision-making, at least with respect to adenotonsillectomy. So these are several papers that try to answer the question of how often can DISE change the surgical plan from a standard adenotonsillectomy in surgically naive children. You can see that there is some variation across studies, which can be attributed to differences in cohort age range or the study samples or how the study samples were categorized. But overall, there is a substantial proportion of children with DISE findings that might prompt something other than an adenotonsillectomy. But what are the DISE findings in surgically naive children? Really, these need to be considered by age group because different findings have been reported in children who are less than 2 years of age versus older preschool or school-age children. And of course, there are significant differences by comorbidity. For example, children with obesity or Down syndrome or neuromuscular craniofacial disorders. And I don't really have time to go into detail in all of these different comorbid conditions, what we might see. I'm really going to focus today more on otherwise healthy children. So these are the DISE findings reported in several papers focusing on surgically naive children. This is not meant to be a comprehensive review of the published literature. There have been several other papers published that I could have included, but these are representative of what has been published. The x-axis lists individual studies, and in the case of Dr. Boudwin's 2018 paper, she separated the findings for the two age groups into infants less than 24 months of age and children 3 to 6 years old. One of her earlier papers also included just children 2 to 6 years of age, and then the two more recent ones showed a wider age range. The y-axis shows the percentage of each study sample with obstruction at a given anatomic site, and the different colored bars represent different anatomic sites as noted in the legend at the bottom of the screen. The first thing you'll notice is that there's significant variation in the findings across studies. This reflects differences not just by age, but also by particular study population. Most of these studies had limited sample sizes in the 20s or 30s, with the exception of Dr. Boudwin's 2018 paper, which had a slightly larger numbers. But in the case of that paper, these are the DISE findings only for the children who were treated with an intervention other than adenotonsillectomy. So in other words, these were the children whose DISE findings resulted in a deviation from the standard intervention. So it's not surprising then that the findings in these children should differ significantly from other papers. Dr. Boudwin's 2014 paper and Dr. Blanc's paper are perhaps the most representative of relatively unselected sample of surgically naive children. And there you can see that most children had obstruction at the nasopharynx or adenoids and the oropharynx or tonsils. But all the studies showed substantial proportions of children with obstruction at other anatomic sites as well, including the palate, the tongue base, and the supraglottis. So these are the percentages of DISE-directed interventions that were performed based on these DISE findings. And you can see that overall adenotonsillectomy was still the most commonly performed intervention. However, a substantial proportion had either isolated tonsillectomy or adenoidectomy. And a small but substantial proportion also underwent some form of medical therapy, orthodontic, or PAP therapy. The one paper that reported a significant proportion of other surgeries like expansion pharyngoplasty or tongue-based surgery was the Demowska paper, which was a bit of an outlier. And the reason for this difference is somewhat unclear. They don't really describe what their indications were for performing DISE, and they don't report a large number of comorbidities. But it's likely that there was some form of selection bias to prompt the DISE, and that may account for their more aggressive surgical approach. So to answer the first question, can DISE change the surgical plan? I think based on the different patterns of obstruction that we have seen, and in particular all the non-adenotonsillar sites that we observed, and the range of interventions recommended based on these DISE findings, clearly the answer is yes. But should DISE change the surgical plan? And this is the second question I pose, and really the main focus I was asked to talk about. And this is a much harder and more controversial question to answer. There are many factors to consider. One of the primary ones, of course, being the range of procedures that you might perform based on the DISE findings. And if you are limited to just variations of adenotonsillectomy, then this is perhaps easier to plan for. If you are going to consider adding in more invasive or involved surgical techniques like expansion pharyngoplasty or tongue-based procedures, then that complicates the operative planning. For example, even just how long to book for the case and what kind of equipment you would need. And that's questionable whether or not that's a good use of resources to tie up a lot of OR time for a procedure that might be very short. There's also the question of whether you would do it as a single versus a staged approach, and how aggressive you are might depend on the severity of the sleep apnea for the given child. And since your surgical intervention is based on the DISE findings, really the indications that for DISE are key in determining whether you should change the plan. Many times, or most practitioners are not performing DISE for every child that's brought to the operating room. And so if your indications for DISE are based on either age or comorbidities, as mentioned by Dr. Kirkham, then this will obviously significantly impact how likely you are to alter your plan from an adenotonsillectomy. And in the case of the US, there are significant insurance authorization practicalities as well, because most insurance companies will not authorize anything other than an adenotonsillectomy as an initial intervention. And only after they have failed adenotonsillectomy can we then offer something else. But to look at some of the outcomes of the DISE-directed intervention in surgically naive children, I won't go into too much detail here since I think this is going to be covered in the next couple of talks, but it's fair to say that overall DISE-directed interventions, both surgical and non-surgical, have been shown to be effective in significantly improving or resolving sleep apnea. These are results from the same studies I've previously referenced with the addition of one by Dr. Kirkham last year as well, and they all show significant improvement in the apnea-hypopnea index from pre-surgery or pre-DISE to post. And so this is one potential algorithm that I think many of us use for the utilization of DISE-directed surgery. After a child who's diagnosed with sleep apnea undergoes DISE, then they may undergo some version of an adenotonsillectomy, whether that's an isolated tonsillectomy or adenoidectomy, or you might consider a non-surgical option as well if there's no obvious obstruction at any of these locations. And then based on whether or not there's persistence or resolution of the sleep apnea, consider further DISE-directed intervention. But one alternative is one that is perhaps illustrated in the Demauska paper, where a more aggressive, really highly tailored surgery, perhaps multi-level surgery based on the DISE findings, is offered at the initial intervention, either in addition to or instead of an adenotonsillectomy, or possibly a non-surgical intervention if they're just determined to not be a good surgical candidate, and then the rest of the algorithm would be similar. And so that it may be that we start moving towards this, at least in certain patient populations, rather than the other version. So in summary, DISE I think is more accurate than an awake clinical exam in predicting adenotonsillectomy outcome. I think DISE can identify non-adenotonsillectomy sources of obstruction and therefore can change the treatment plan. We've seen that DISE-directed interventions can successfully treat sleep apnea, but really we need further study to better determine if the DISE-directed interventions are actually superior to adenotonsillectomy, and to define the optimal treatment algorithm for DISE-directed intervention. So that's the end of my talk. Thank you very much, and feel free to email me with questions.
Thank you very much, Dr. Lam, for your excellent talk on DISE findings and surgical decisions. Next, we will be updated on the surgical treatment options for children with persistent OSA by Dr. Palmer Benedek, who is a pediatric otolaryngologist and sleep specialist at Heimpal National Pediatric Institute in Budapest, Hungary. So now I'll pass on the word to you, Dr. Benedek.
Thank you, Tina. So first and foremost, I would like to thank Dr. Bardavins for inviting me to this session. Now I turn my camera off so it will be easier for you to focus on the slides. The first-line treatment for obstructive sleep apnea in children is adenotonsillectomy. The success rate of this procedure is 75% in otherwise healthy, non-obese children. On the other hand, 10 to 77% of patients with comorbidities experience remaining symptoms, depending on the type of comorbidity present and other risk factors. Here are the risk factors for persistent sleep apnea. They can be perinatally determined, such as micrognathia, macroglossia, midface hyperplasia, or in normally developed patients when there is substrate deposit or infiltration between upper airway tissue. And finally, in cases with increased airway collapsibility, which can be caused by local inflammation, such as asthma or allergic rhinitis, or perturbations in neuroreflexes, for example, cerebral palsy and neuromuscular disorders. So what are the aims of surgery then? To increase the diameter of the upper airway and to stabilize hypotonic muscles, thereby decreasing tissue collapse. Now, I would like to present to you the possible surgical solutions for each level of obstruction from the nose to the larynx. Starting with the nasal cavity, one of the main obstructive agents here is the enlarged inferior turbinates. The solution in this case is submucosal turbinoplasty using radiofrequency. The other cause in the nose could be septal deviation, when we should perform septoplasty. It's quite rare that septal deviation is the only cause of persistent sleep apnea, but it could be a part of multi-level surgical option in older children. The next level is the oropharynx. After adenotonsillectomy, the collapse of the pharyngeal wall could obstruct the airway here, as you can see in this video. The surgical solution of pharyngeal wall collapse is some type of pharyngoplasty in adults, but these procedures are not first-line treatment of sleep apnea in children. There are only a handful of studies about modified pharyngoplasty in children. Some of them found improvements in sleep parameters, as you can see in Prolapse and colleagues' article. We can perform it with adenotonsillectomy or by itself in persistent sleep apnea cases after tonsillectomy. Before the procedure, sleep endoscopy is needed to determine the type and level of obstruction. In my practice, I usually do it with tonsillectomy in patients who are at risk, as I've explained before, to avoid the postoperative respiratory complications. I usually perform Professor Peter Corte technique. I think you all know Professor Peter Corte and his work in our field. Here you can see the indications of the procedure. It's my pleasure to show you the procedure itself with Professor picture. I'd like to thank him for providing these pictures for me. So after the total tonsillectomy, identify the fulcrum where the palatopharyngeal muscle turns toward the palate. Pass the C1 atraumatic needle loaded with 2 O-braided absorbable suture through the palatopharyngeus 2 mm below the fulcrum, going from lateral to medial. The suture is then passed through the palatopharyngeus 2 mm above the fulcrum, going medial to lateral. The needle with the attached suture is then passed from the apex of the tonsillar fossa into the retromolar trigone, making sure they engage the tough fibrous tissue behind the last molar. Thread the second needle onto the tail of the 2 O-braided absorbable suture. The second needle with the thread suture is then passed from the apex of the tonsillar fossa into the retromolar trigone, parallel to the line of the first pass. The 2 sutures are tied with a square knot after pulling the palatopharyngeus superolaterally. And here are the before and after pictures. After tonsillectomy, we can often find lingual tonsillar hypertrophy, which is a follicular hyperplasia histologically. It can be cause of it can be the cause of snoring or even sleep apnea. Here you can find Dr. Friedman's lingual tonsil grading system, as Dr. Kirkham mentioned. The grade 1, when there is no obstruction. Grade 2, when the lingual tonsil fills less than 50% of the vallecula. Grade 3, when more than 50% of the vallecula is filled with the tonsil. And grade 4, when we are unable to see the epiglottis. The solution in cases with lingual tonsillar hypertrophy is lingual tonsillectomy. The indication of the procedure is a grade 3 or 4 tonsillary hypertrophy. The risks are the same as those of adenotonsillectomy: bleeding, dehydration, pain, dysphagia, or airway obstruction. In a meta-analysis, Coe and his colleagues found that after lingual tonsillectomy, the apnea-hypopnea index decreased by almost 9 events per hour. The nadir oxygen saturation increased by 6%. The apnea-hypopnea index of 17% of patients was reduced to below 1, and in 55% of cases, it decreased to below 5. The complication rate was 6.8%. I'm sorry. Here you can find the possible treatment options of posterior tongue-based obstruction. We have several options, but the most important thing is that we need to plan every patient's treatment individually. The last level is the larynx. We may find laryngomalacia here, of which there are 3 types. This was discussed in an article by Reinhardt and colleagues from Lausanne. Type 1 laryngomalacia, when the supraerythenoid floppy tissues are prolapsing. Type 2, when the area epiglottic folds are shortened. This is associated with the long omega-shaped epiglottis. And type 3, when the overhanging retroflexed epiglottis collapses posteriorly during inspiration. Now I would like to show you 2 examples of laryngomalacia. First is of a patient with type 1 laryngomalacia. The floppy supraerythenoid tissue can be seen, which is blocking the airway during inspiration. The solution in this case is a supraglottoplasty. We use it with radiofrequency ablation. Here is the endoscopic view of the larynx after the procedure. The next is a patient with type 3 laryngomalacia. You can see that the lateral pharyngeal wall partially collapses. Moving on the level of the larynx, the epiglottis can be seen as it is collapsing posteriorly against the pharyngeal wall. The treatment in this case is epiglottopexy. So treating persistent sleep apnea is always a challenge. I would like to demonstrate it with a case. He's a 9-year-old boy with obesity and hypertonia. He underwent adenotonsillectomy more than 7 years ago and needed to stay in the intensive care unit for 3 days postoperatively because of desaturations and due to his need for oxygen. He had readenotomy 1 year ago. He arrived at our emergency department So he arrived at our ENT department wheezing, gasping, and with severe daytime sleepiness. So we performed polysomnography and found severe sleep apnea syndrome with apnea hypopnea index 79 events per hour. Desaturation index was 82.2 events per hour, and the nadir oxygen saturation was 53%. Our plan was CPAP titration, but we couldn't find to the severe pharyngeal concentric obstruction, the larynx was not visible. That's why we used video laryngoscopy, and with the video laryngoscopy to examine the larynx and found type 1 laryngomalacia, which explained our difficulties with the CPAP. The first night after supraglottoplasty, he suffered from desaturation, but it was only 70%. Polysomnography was done after 2 days. We still found severe sleep apnea with the apnea hypopnea index 83.9 events per hour, and the nadir oxygen saturation was 66%. CPAP titration was repeated with success. So here you can find his parameter, and he spent 11.8% of his total sleep time under 90%. There was a sleep study after 2 months when the apnea hypopnea index and the oxygen saturation didn't change. So we changed the pressure. And after 3 months, his symptoms resolved with the CPAP, and we found only mild sleep apnea. And his blood pressure normalized. So in conclusion, we can say that we always have to treat patients with persistent sleep apnea individually. Preoperative evaluation is always needed. Surgery improves sleep parameters, but sometimes doesn't resolve the disease itself. That's why we often need to combine surgical and medical treatment. Thank you for your attention.
Thank you very much, Dr. Benedict, for your great talk. Now we will move along to the non-surgical treatment options for children with persistent OSA by our final speaker, Professor Steen Verholst, who is a pediatric pulmonologist and sleep specialist, and he's also head of the Department of Pediatrics at the Antwerp University Hospital. The word is yours, Professor Verholst.
Thank you for the introduction and for the invitation as a non-ENT physician to discuss with you some of the non-surgical treatment options we have for children with persistent obstructive sleep apnea. First, I would like to highlight some of the main references that were used for this presentation. And the top 2 are what we think very important papers. They come from a multidisciplinary consensus statement on the diagnosis and management that was published in the European Respiratory Journal. So first, let's discuss about the scope of the problem. Like my previous colleagues already mentioned, the further management, I think, will foremost depend on the patient characteristics. And I think that we can discuss two main groups. I think first group are the normal weight, non-syndromic children with prior adenotonsillar hypertrophy. And as already mentioned, these children will not form the main problem of persistent obstructive sleep apnea after adenotonsillectomy. However, as here depicted in red, there are several risk factors for residual OSA after adenotonsillectomy. First, consisting of severe OSA, but also with medical comorbidities or local ENT or orthodontic abnormalities. But as already said, I think that the most important group to consider are children with comorbidities, with underlying syndromes, in short, children with more complex upper airway obstruction or complex obstructive sleep apnea. That includes children with obesity, genetic syndromes, Down syndrome has already been mentioned, children with craniofacial disorders, neuromuscular disorders, or neurological diseases such as cerebral palsy. To illustrate one of the papers on our group looking at the effects of adenotonsillectomy in children with Down syndrome and obstructive sleep apnea, when you just look at the mean values of the apnea-hypopnea index, you see that after adenotonsillectomy, you get a significant improvement in obstructive sleep apnea severity. However, when you look at the individual patient data in more detail, you see here in orange that you have a very high prevalence of persistent obstructive sleep apnea after adenotonsillectomy, in this case in children with Down syndrome, but that's also true in children with other underlying conditions. Also, you can see two groups. You can have responders, children who respond very significantly to adenotonsillectomy, but also you have non-responders, where in which in some cases the apnea-hypopnea index even increases after surgery. So this treatment algorithm been shown, and I will go briefly into it. I think that when you have an abnormal polysomnogram after adenotonsillectomy, it will not only depend on the patient characteristics, but it will also depend on the degree of persistent obstructive sleep apnea. In children with milder forms of sleep apnea, you will have the option of starting them on anti-inflammatory treatment, and that is something that we will discuss. But if the persistent sleep apnea is more severe, then you need another upper airway evaluation to direct you to the most appropriate treatments. And then you can have site-specific treatment, you can have treatment of contributing factors, but where we will focus the rest of this presentation on will be on the initiation of CPAP therapy or non-invasive ventilation, because that treats, of course, the entire upper airway. So very briefly about anti-inflammatory treatments. Montelukast is a leukotriene receptor antagonist. It is the best studied, although there are a limited number of studies, but these studies include some randomized controlled trials. This is one of the first randomized controlled trials of montelukast in children with sleep apnea, published from the Israeli group. And you clearly see that in the montelukast group, there is the obstructive apnea index. And this has also been shown in limited but other data. However, I think it's very important to say that we have no idea, no studies about what montelukast or other forms of anti-inflammatory treatment does in children with persistent sleep apnea and with underlying conditions. So I think that's certainly an area for further studies. But the main focus of my presentation will be on CPAP therapy and non-invasive ventilation. This slide from an older study, but just to show you that CPAP therapy in children is not a rare therapy. It is more frequently applied, and you see here over the years that the number of children from this hospital put on CPAP therapy or non-invasive ventilation is steadily increasing over the years. So what are the indications to start CPAP therapy? And this is data from our European Respiratory Society Task Force. We first started with infants in children below the age of 2. And there CPAP can be considered often as a first or second-line treatment. So we will reserve CPAP therapy for children with moderate to severe obstructive sleep apnea who are either no candidates for upper airway surgery or who improve after surgical intervention. We know in this group that CPAP is in general an effective and well tolerated treatment, and also very importantly that it can be applied as a temporary bridge, a temporary treatment to a second, most of the times, a surgical intervention. Of course, BiPAP therapy, non-invasive ventilation, has been used in children often with complex other conditions where there's not only sleep apnea, but also associated hypoventilation. Most studies report that CPAP therapy in this age group is very well tolerated with only minor complications. There is some occurrence of craniofacial abnormalities, such as mid-face flattening. We will come back to that later in the presentation. But it also has to be said that the long-term consequences and the potential reversibility of this complication is currently unknown. In older children, CPAP therapy is mainly reserved as a third line treatment. So you see it here in the red box as well, reserved for children with moderate to severe persistent obstructive sleep apnea after adenotonsillectomy, and especially related to underlying conditions. Of course, it works in the age group. It is associated with improvements in obstructive sleep apnea severity, in gas exchange, in neurocognitive complications, sleepiness, behavior, and quality of life. It has the same relatively minor complications that we know from CPAP therapy in adults, but it can also cause in this age group some craniofacial complications. Just to show you some more data about these craniofacial complications, this is data from Brigitte Farou's group in Paris. And you see here that in a relatively large population of children treated with CPAP and non-invasive therapy, facial flattening was observed in the majority of patients, in about 68% of patients. And another complication, maxillary retrusion, was observed in about 40% of patients. However, it is important to note that about half of these patients already had an underlying disease that favored maxillary retrusion. But of course, it is a worrisome complication that needs to be addressed, that needs to be followed, and that also needs to be tackled in a multidisciplinary program. One of the main treatment factors or preventive factors for these of therapy is a good fitting mask. And in ideal situations, we try to give the patients 2 different types of masks to distribute the pressure around the face more evenly. Luckily, the situation is different than 5 to 10 years ago, that we now have more and more commercially available masks to our disposal. I also would like to draw your attention to the OptiFlow nasal cannula, which you probably know from use in the intensive care units. but it can also be used to treat those children who require CPAP therapy, but who are intolerant to a common nasal mask. So in the clinic, we use it quite a lot. Adherence is, of course, CPAP is not a straightforward therapy. So adherence, especially in older children and adolescents, needs to be monitored. Very briefly, some older and mainly non-European literature, mainly coming from the US, showed suboptimal adherence. But when you look at that literature, you have to know that adherence is not always objectively assessed, and sometimes in these older papers there was a lack of a close follow-up. But very interestingly, some studies in obese adolescents on CPAP therapy have shown that even suboptimal adherence, CPAP used for 2-3 hours in the night, can already result in improvement in neurocognitive functioning. But if you look at more recent literature, and the main literature is again originating from Brigitte Verroe's lab in Paris, you see that CPAP therapy, that adherence of CPAP therapy can be quite excellent. You see here adherence rates of more than 8 hours per night, which is excellent. And also in children with neurocognitive syndromes, for instance, here in Down syndrome, you here also see in the green box that there is excellent compliance possible for CPAP therapy. So to conclude my talk, I think that this is the main message of this symposium, that the etiology of persistent obstructive sleep apnea in the individual child should be determined. There can be a role of pharmacological treatment in children with mild persistent obstructive sleep apnea, but we need more research on the effects of pharmacological treatment in children with underlying conditions. Therapy is more and more used in children with persistent obstructive sleep apnea. It has a more prominent role, more of first-line treatment role in infants, according to the exact etiology, and it has a second or third-line treatment role in all older children. And of course, we have some craniofacial complications and adherence issues that need to be addressed. Thank you for your attention.
Thank you so much, Professor Verhulst, for sharing your expert knowledge with us from a pulmonologist perspective. This was it from our speakers. We're now ready to answer some questions. I can see that some of the questions have already been answered during the session, but we still have a few questions. So this one is for you, Dr. Kirkham. Approximately how long time does a
That is a great question. I think, from the actual video recording usually takes less than 3 minutes, but it takes some time to get the patient in the right plane of anesthetic. And when the anesthesiologist is using dexmedetomidine, usually they will titrate it in over about 10 minutes, and it can take some time to get them in the right plane. When they're using propofol, it's a bit faster. So I think the overall, usually when we're using propofol, I estimate that it adds about 15 minutes to the case to do a DISE. So if you're doing an adenotonsillectomy, you can plan to add about 15 extra minutes to do DISE.
Okay, thank you. There is